the event is about robotic surgery, and there's no better person than our speaker today, so Mr. Kusuma Murthy, and he graduated from the University of Health Sciences in India and completed his surgical and urological training in 2010. He also gained further experience in working at a leading hospital in Manchester and Guy's and St. Thomas Hospital in London. Subsequently, he undertook a uro-oncology fellowship at Colchester. He was awarded his fellowship of Royal College of Surgeons in 2015 and completed his fellowship in robotic surgery from European Robotic Urology Section Certified Training Center at Guildford. So currently he's working as a consultant urologist at James Cook University Hospital in Middlesbrough. So ladies and gentlemen, please welcome Mr. Murthy.
Thank you, Abhaya, for the introduction. Good evening, everyone. It gives me immense pleasure to speak to highly skilled professionals in engineering and technology about robotic surgery. I don't have any conflicts of interest. Surgery can be divided into three eras of modern surgery: open, laparoscopic, and the robotic. Conventionally, open surgery was performed with long incisions, resulting in significant pain, blood loss, and prolonged hospital stay to the patients. Later on, laparoscopic surgery was developed, which is also called the keyhole operations, to counter the effects of open surgery. But laparoscopic surgery has limitations of limited range of motion as well as limited dexterity. Robotic surgery was developed to counter the limitations of laparoscopic surgery and also to enhance the capabilities of surgeon. So what is robotic surgery? Robotic assisted surgery is the use of computer technologies working in conjunction with robot systems to perform various surgical procedures. The term robot was introduced by Czech writer Karel Čapek in 1921. He used it in his play called Rossum's Universal Robot. The term robot means forced labor. The theme of the play was scientists invent the robot to help people for performing simple repetitive tasks. However, when the robots were used in fighting wars, they turn against their owners and take over the world. Coming to the development of robotic surgery, I would say the development of robotic surgery is a very good example of interdisciplinary collaboration between medicine, engineering, robotic technology, optics, and computer science. The first digital and programmable robot was invented by this gentleman named George Devol in 1954. And he named the robot as Unimate. And this robot was specifically designed to carry out hazardous tasks like spot welding and molten die casting. This robot was acquired by General Motors and used it in car assembly, and it was a huge commercial success. The first medical application of the robotic surgery was used to orient a needle for a brain biopsy under CT guidance, and it achieved an accuracy of 0.05 millimeters. In England, the Imperial College of London created a robotic system called Probot, and this gentleman is Mr. John Wickham. He's a urologist who deals with diseases of kidney, bladder, and prostate. He did this, used this robot called Probot to assist in resection of prostate for enlarged prostate in 1991. During the same time, integrated surgical systems produced a robot called Robodoc. This robot is mainly used for drilling and milling of the femur shaft or the thigh bone during hip surgery. I would say the main driver for modern day robotic technology is the development of telepresence surgical system. This is in collaboration with NASA Ames Research Center and Stanford Research Institute International collaborated to produce a mobile armed vehicle to help soldiers in the battlefield. The mobile armed vehicle had a robotic system and it was remotely controlled by surgeons. This was mainly to prevent or to manage life threatening injuries for the soldiers. Later on, the Intuitive Surgical acquired this technology and designed the Da Vinci robot. The Da Vinci robot is the one which is most currently used throughout the world. Initially, the first surgical robots were used to support, move, and orient the camera in the operating field. Later on, they evolved into more complex surgical robots in which the surgeon operates from a remote console far from the patient. Most of the robotic systems which are currently available are master slave systems. They are not autonomous. The master is the surgeon and the slave is the robot, and the surgeon controls the robot. Computer motion introduced the first laparoscopic camera holder. They've created a robotic arm to hold the camera during keyhole operations. And this robotic arm was controlled by the voice of the surgeon. And this is the first robot to receive FDA clearance in 1994. Subsequently, the same company developed the JUICE system. The JUICE system was developed in 1995 and it had an ergonomic console for the surgeon to operate and three robotic arms, including the ASOP camera. And the JUICE system carried out in 1998 the first coronary artery bypass in a beating heart. The same system carried out the famous Lindbergh operation. This is a complete telesurgical operation in 2001, where a French surgeon named Professor Jacques and his team, located in New York, operated on a patient in Strasbourg, France, which is nearly 3,000 miles away. They used the same JUICE surgical robot, and the link between the robotic system and the surgeon was provided by a high speed fiber optic service by French Telecom. The Intuitive Surgical designed the Da Vinci system, which is the most commonly used robotic system for surgeries worldwide. Essentially, it has three components, mainly the surgical console, the robot, and the vision cart. The surgical console is the place where the surgeon sits, and it is ergonomically designed. It has a natural hand-eye positioning. It provides 3D imaging and magnification 10 times. It also has a built-in microphone to facilitate efficient communication with the operating room staff. In addition, as mentioned earlier, on the left side of the screen is the vision cart where the assistant sees the operation. It also has energy devices to perform various tasks. On the right side of the screen is the actual robot, which has four intuitively working robotic arms. The key feature of the Da Vinci system is the instrumentation. The instrumentation is called the endowrist instrumentation. It mimics the movements of the human wrist and intuitive motion. Each instrument has 7 degrees of freedom, 3 translational, 3 rotational, and 1 grip. The tip of each instrument allows 90 degrees of articulation. This is a short video showing the the endowrist instrument. As you can see, the wristed instruments are performing suturing on a sponge. Surgeon is sat at the surgical console and he is controlling these instruments. As highlighted earlier, the three components of the robot and the surgeon controlling the masters. These movements are transmitted to the robot, which is connected to the patient. This is the binocular vision, which provides a three-dimensional imaging. The Da Vinci has a feature of a dual console, which is very useful when you are training a new surgeon. The surgeon can take over the control as and when required. The other feature of the Da Vinci robotic system is motion scaling and tremor reduction. Motion scaling is the large movements by the surgeon are translated into fine, precise movements of the robot instruments, eliminating the tremor of the human hand. And the motions are intuitive. That means the movements of the instruments attached to the robotic arms replicate exactly the movements of the surgeon's hand. This is another short video where I got a chance to record it when the intuitive engineers were servicing the robot. You can appreciate from this video the movements of the robotic arms, the degree of the range of the movements and the intuitive movements can be appreciated in this video. Since the inception in 1998, the Da Vinci has significantly improved their systems, both in terms of vision and maneuverability and advanced instrumentation and enhanced instrument capability. The most currently used system is the Da Vinci Xi system, which is launched in 2014. And it is specifically designed to, uh, to perform highly complex multi-quadrant surgery. The features include revolutionary anatomical access, and it is a platform for advanced technologies. And this machine is endorsed by various subspecialties in surgery. The Da Vinci also introduced a single port system, which is launched in 2018. This has a fully wristed Da Vinci endoscope, 360-degree rotation, and three fully wristed elbow instruments installed through a single cannula. The XI system has four arms, so it requires four keyholes to operate on a patient, but the SP system can operate through a single keyhole. So cosmetically, it is very effective, and it can also be operated through the natural human orifices without needing to make a surgical incision. It's not very widely used in the UK, but it is well used in the USA. As you can see from this slide, since the inception, around 7 million operations were performed by Da Vinci robot, and globally there are around 5,500 systems are in place. And this slide shows the worldwide procedure trend. As you can see, there is a significant growth of the utilization of the Da Vinci system worldwide. The same slide shows the endorsement of the Da Vinci system by various surgical specialities. As you can see, in the last few years, general surgeons have uh, used it quite increasingly. The Da Vinci robot in the UK, around 110 systems are in the UK since 2001. They are mainly used for urology, gynecology, colorectal, cardiac, and ENT specialities. Almost 90% of prostate cancer surgeries are performed by the robot in the UK. There are widespread applications of robotic surgery. I am a urologist. We are the forefronters to adopt this technology. General surgeons are using it for operations on the gallbladder, hernia operations, and various abdominal operations. Gynecologists are using for carrying out hysterectomy and prolapse operation. Pediatrics are using for reconstruction of the urinary tract. ENT surgeons are using it for treatment of oral cancers and tonsils removal. And radiation oncologists, are using it for radiosurgery, also called the cyber nerve surgery. I'm a urologist who deal with the problems in kidneys, bladder, prostate. So I'll be talking about the applications of Da Vinci robot in urology. It's mainly used, as mentioned earlier, for prostate cancer surgery, bladder cancer surgeries, and also partial or complete removal of kidney tumors, and also reconstruction of the urinary tube connecting the kidney with the bladder, and also rejoining of the urinary tube into the bladder, and many more operations. I will talk a little bit more about robotic prostatectomy. It is mainly performed for patients who got localized prostate cancer. The positioning for robotic prostatectomy, as you can see from the pictures, is a steep head down position, that is to avoid the bowels to fall away from the pelvis. The prostate is situated in the pelvis, and the robot is docked so that there is no bowel interference when the robot is being operated. So initially, the tummy is inflated with carbon dioxide gas, and various ports are placed as shown in the picture on the left side, and the robot is connected to these ports. This is a short animated video of what happens during a prostate operation for prostate cancer. As you can see, the prostate is situated in the pelvis. On top is the bladder, and in the bottom it is connected to the P passage. In prostate cancer operation, the prostate is removed and the bladder is rejoined to the P passage. This is an actual video performed by me for a patient who was suffering from prostate cancer. We removed the prostate in this patient. As you can see, the robotic instruments are controlled by a surgeon console. The lower end of the screen, you can see the black suction thing. You can appreciate the tremor. This is operated by the assistant, which is a human hand, in comparison to the robotic instruments, which are quite stable. This is the prostate gland with the cancer, and on top is the bladder, and at the bottom is the P passage. As shown in the animated video, the idea of the operation is to remove the prostate and rejoin the bladder to the P passage. And these instruments are connected to various energy devices for coagulating blood vessels and cutting. The blood circulation to the prostate is controlled by clipping the vessels which are supplying the prostate by various clips which are either made of plastic or metal. I will quickly, the prostate is placed in the specimen bag and it is removed through one of the keyholes. See the instruments, as you can appreciate, the wristed motion of the instruments, which is used for carrying out various tasks. In this case, I am stitching a, a, a big vein which supplies the prostate gland to control the bleeding. Then, as shown in the animated video, the bladder is rejoined to the P passage with the help of the stitches. You can appreciate the wristed movements of the instruments. The suturing is done with very fine precision. And the image is what the surgeon sees is magnified image 8 to 10 times, which immensely helps the surgeon in identifying the key structures. So in the end, as you can appreciate from these two pictures, the one on the left side is the keyhole operation done with the help of a robot, and on the right side is the conventional open operation. You can see a long incision in the open operation and tiny incisions in the keyhole operation. And you can imagine the amount of pain the patient experiences in an open operation with a long scar. So the advantages of robotic surgery are less pain, faster recovery, and shorter hospital stay. And there is also less blood loss and less need for blood transfusion. Because the incisions are very small, there is also a less risk of infection. And the surgery is performed with enhanced precision and decreases the fatigue of the surgeon. The other benefits of robotic surgery are telesurgery, which is operating remotely, and telementoring, which is training surgeons remotely. But there are some disadvantages with the robotic surgery. The main disadvantage is the cost. The normal XI machine, this is a rough estimate, costs around 1.4 million pounds, and the annual maintenance is around 140,000. And disposables instruments cost around 2,000 per case. And there is a steep surgical learning curve involved with robotic technology, and the theater staff and the scrub team also need to be trained. In the initial period of inception of a robotic program, there is an increased theater setup and turnover time. But the disadvantages are offset by less pain, early recovery, and less hospitalization. The intuitive Da Vinci enjoyed a monopoly for the last 20 years. This is because of restrictive patenting, maintaining a high quality uh, equipment, excellent customer care, and worldwide installation base. But the patents expired a few years back and new robots have come up in the market. The one is the CMR, which is the Cambridge Medical Robotics System, developed a robot which was introduced last year, and it is called the Vercius Robotic System. The main difference between the Da Vinci system and the Vercius system is, as you can see from the picture, the, the surgeon console is open and the robotic arms are independent and they are much sleeker. So they can be easily moved in between theaters, and the communication between the surgeon, anesthetic team, and the scrub team is very effective uh, because of the open console. In addition, it has also the benefits of the conventional Da Vinci robot. This is a short video of the CMR surgical system, courtesy by the CMR Surgical Robotics. As you can see, the wristed instrument, similar to the Da Vinci. This is an open console where there is an effective communication between the surgeon, the anesthetist, and also the scrub team. Coming back to the other new robotic systems which are developed, one is the Senhance surgical system developed by Transentrix in USA. It is already used in gynecology and colorectal. The other robot is the South Korean robot, which is also called the Revo 1, which is also in use in general surgery and prostatectomy. Medtronic is developing a robot. It is still in development. And Verb Surgical and Stanford Research International with Google are developing a robot. And most of these robots have features of three separate robotic arms and reusable arms. And they also have haptic feedback, which is sensing the tissue with the instruments when operating with the robot. As mentioned earlier, uh, just like the Da Vinci SP system, the new robotic systems with single port are also being introduced. One is the Surgibot, Transentrix, Sport Titan Medical, and the other companies are also manufacturing single port. They are still in development. So what is the future of the robotic surgery? The future of robotic surgery is very bright. The robotic systems will capable of functioning remotely at greater distances will be possible with the introduction of 5G and 6G technology, which is still in research phases. The robots will become smaller, equipped with artificial intelligence, which will alert if there is any error being performed by the surgeon. Nanotechnology is also keeping in full pace. Nano robots are being developed where they can be injected into the body, where they go to the site of the problem and deal with it. Cost of the robots will significantly decrease as more and more companies are coming into the marketplace, resulting in competition. And a cloud-based software system should be developed which will allow the robotic platforms to work collectively to improve efficiency and productivity. And research will continue at an acceleration pace. And we in the UK are the first to start a trial called the Mastery Trial, which uh, measures the automatic performance metrics of the surgeon. And this metrics will be used as a benchmark for training future surgeons. So, in conclusion, the introduction of robotic technology revolutionized the way the surgery is performed. It has shown clear benefits to patients in terms of reduced pain, shorter hospital stay, and earlier return to normal activities. Thank you.
Okay, so thank you very much. And we are already started getting lots of questions. So let me
Yeah.
just, you can also see the questions, Murthy, if you want to, but I will read it for you. If you
Yeah.
click on the Q&A button, it'll appear. So the first question is, have you experienced the UK's new Versius robotic?
Yeah, that's the one which I've talked about. Only 4 centers are being using that system, and I am used to the Da Vinci system. But the feedback I get from my colleagues is it is a very good system in comparison to the Da Vinci system.
Okay, the next question, Andy wants to know, what are the comparative outcome measures for open and robotic surgery in urology prostate surgery?
Oh, that's a good question. Uh, Robotic surgery has clearly shown benefit in terms of blood loss, less pain, early recovery, reduced hospitalization, and getting back to work quickly with robotic technology. The robotic technology also shown clear benefit in terms of positive margins. This is quite a technical term where when we do an operation, we ensure that the margins are negative. And robot has shown superiority over open surgery in terms of positive margins as well.
Okay, so the next question, John wants to know what is the white cylinder seen in the prostate operation? Is probably one of your videos. Perhaps
White cylinder. Is it in the video or?
perhaps John, you can chat, make the question a little bit clearer. I'll move on to a different question. So until John sends us some more details. And does the robot need to cauterize where it cuts? If so, how does it do it?
Oh, right. Yeah, the robot instruments need cauterization, and the instruments are connected to a diathermy machine which coagulates and cuts.
Uh, okay, so the next question is what precautions are taken in case of a power cut?
Yeah, that's a very good question. Uh, it rarely happens, but if it does happen, then we can undock the robot and perform the normal conventional open operation or laparoscopic operation.
Okay, so the next question is how intuitive is the use of controllers in the Da Vinci robotic system, and how many hours of training did you need to carry out to get used to the controls?
Yeah, the recommendation is at least 50 hours of simulation exercises to be done to get used to the system.
Okay, so the next question is about the. I think Roger says he doesn't understand why one of the advantages is greater precision. If the instrument is following the surgeon's movement, then how can that be?
As I mentioned, the motion scaling is a key feature. Normal human hand has a tremor, and in the robot, that tremor is eliminated. That's why it is more precise than a human hand.
Okay, so Philip Brown is asking, can robotics be used for brain surgery?
Yeah, they can be used for brain surgery. As I mentioned, in fact, in the history, the robot is used for carrying out a brain biopsy long back in 1985.
And Rod is asking, does the Versier's system have binocular vision?
Yeah, it does has binocular vision, similar to Da Vinci.
Joe is asking, what does safety features have to be incorporated into the robotic system?
The safety features are, I mean, it is quite an intelligent system. If there is any error, the robot alerts us by showing a recoverable or a non-recoverable fault. The non-recoverable fault cannot be recovered. We have to switch off back the robot again. But a recoverable fault, the robot tells us where the problem is, and then we can rectify it on table. It's quite an intelligent system in terms of safety.
So, okay. So Martha is asking about the advantages and the disadvantages, which you explained, but she also asks, with CMR robot, does the surgeon have a 3D vision? Do you think CMR is the future? What is CMR, by the way? I don't.
CMR is Cambridge Medical Robotic System. It is a robot developed in the UK. I don't have much experience with that, the robot, but it it provides a three-dimensional vision, as I understand, and the maintenance costs and the running costs are much cheaper than the Da Vinci system, as far as my knowledge about this the new robot is concerned.
Okay, so that's a very interesting question, I think, from a patient's point of view. So I
Yeah.
don't understand all the words, but you may be able to explain. So I recently had an RSRARP plus NeuroSafe with Professor Eden at Guy's and the Da Vinci Xi. Thankfully, so far, pentafecta outcome and amazing as was up and walk the next day. So, do you find robotic surgery is more comfortable for the surgeon in terms of back strain?
Yeah, it does. The surgical console is ergonomically designed, and so it eliminates the fatigue and back strain of the surgeon. And the surgeon doesn't need to scrub during the operation. If he has some fatigue or back pain, he can just stretch by just getting up from the console. And without surgical control, the robot doesn't move. And coming back to the gentleman who was operated by Professor Eden, Professor Chris Eden is one of my mentors. I was trained under him. He's an excellent surgeon, and I think he had the surgery from one of the best surgeons in the UK.
Okay, so interesting. And Alex is asking in the CMR video, what were the glasses the robot operator was wearing?
I think it's the three-dimensional vision, the 3D glasses.
Okay, so Alex is also asking which will be the next surgical branches to use robots and which will be the last.
The urologists have endorsed the robot long back, nearly 20 years. The robot is picking up in various specialties, general surgery, cardiology, uh, gynecologist, and ENT. So it can be used in any surgical specialty. And I envision that it will be adopted by various other specialties as well.
Okay, so just a reminder, if you have any questions, please put it on the chat, on the Q&A window, not on the chat window, please, so I can track them. I asked, I think the previous, John, who asked a previous question to just to put a comment to expand his question. I think the question was what was the white cylinder he was saying. Okay, so I can't see anything. But then, okay, so the next question is, how is the Da Vinci manufacturer responding to the new competition?
Yeah, I mean, obviously, when there is a competition, the current system which is in place will be more cautious, and they will think further than the competitors, which is good for them. As I mentioned, Da Vinci has established themselves as a monopoly for the last 20 years. So it will take at least 5 to 10 years for the new robots to take over Da Vinci.
Okay, so Alex again is asking, you mentioned a UK trial looking at surgeons' performance metrics. What are these metrics?
These are the automated performance metrics, which when the surgeon moves the hands in the console, the the intuitive company has designed a machine which records the movements, and they will analyze it, and then they will give us information about how good the movements are. They compare it with a standard. So this is a trial which is going to start soon, and my hospital has been chosen to carry out the trial.
Okay, so the next question is, what's the comparative price for the various systems?
That's a difficult question to answer because the price is negotiated by the companies with the hospital trusts. But as I mentioned, the Da Vinci system costs around 1 to 1.5 millions pounds, but I'm not aware of the price range of the new robots which are coming.
Is robotic surgery quicker to perform?
Yeah, it is quicker, but as I mentioned, it has a learning curve. In the initial period, the operative times may be longer, but as the surgeon gains experience, the theater staff gains experience with the robot, the operation time is significantly shorter than a conventional open operation.
I think also related to that, what's the time frame for training the complete surgery staff from the beginning to advanced user?
Yeah. So, as I mentioned, it needs 50 hours of simulation, and at least the surgeon who does the robotic prostate operation, talking about prostate cancer operation, the recommended number of cases to become competent is 150 to 200 cases. After that, he becomes a competent robotic surgeon.
Okay. And the next question is, why is robotic surgery not popular in neurosurgery compared to the other specialties?
It has to be adopted by the surgeons, and neurosurgery, as mentioned, it is quite, robotic arms are used to carry out finer tasks in neurosurgery, but the conventional Da Vinci system is designed for mainly for intra-abdominal operations and surface operations. So the brain operations are enclosed in a cranial, which is the cranium, the skull bone. So after opening the skull bone, the robot can be used to carry out finer tasks. It can be used in neurosurgery as well.
Okay, so Murthy, we are engineers, so I think we have to probably this expect this kind of questions. Is it possible to machinery to be ever hacked?
Uh, at the moment, I wouldn't say no, because it's specifically it is enclosed in that theater. The console and the robotic instrument are controlled by that specific console. As mentioned, if there is a cloud-based software which shares the robot uh, across multiple hospitals, then there is a chance for hacking.
So Peter Smith is asking, given the relative high cost of the equipment, what would the expected life of after installation?
The robot can last for many years. It depends upon how the manufacturer provides the maintenance, but a standard robot can work for 10 to 15 years without any problems.
The next one is, how far are we away are we from autonomous robot surgery?
I think autonomous robots uh, are the future, but uh, probably it takes at least 20 years down the line. And a lot of ethical concerns are also involved with autonomous robots, that who is going to take the accountability if an autonomous robot is performing an operation. I don't think the robots will be completely autonomous when it comes to human operations. It will be controlled or supervised by a surgeon.
And again, interesting question, Murthy. What is the latency of the system and how does the surgeon or the system handle these delays?
There is hardly any latency when we are doing a robotic surgery. As mentioned, the movements are directly transmitted to the robotic instruments without any delay. But certainly, the latency will be a problem when we are doing a remote operation. Especially, it depends upon the bandwidth and how quick the internet is if we are operating remotely.
And does the software update itself over the time? If yes, where
Yeah,
those
yeah.
up?
If the software needs maintenance, the intuitive engineers, they come regularly and update and upgrade the software as and when required. That's why the maintenance costs are also high for this machine.
Um, what will be the approximate, I think, approximate cost per prostatectomy? So I guess the approximate cost, machine cost. I think you mentioned about the machine cost. It's as much as you can probably. Let's move to the next question.
Yeah.
In future, will surgeries ever be completely done by machinery? How does the surgeon exactly know when I think high focus suturing at such a high focus, and would it not be difficult to suture with such high precision? This
Yeah, I
is
mean, I think it's the same question which was asked earlier, like autonomous robots, I guess, which I've answered earlier.
okay. So, can the system be used for heart valve replacement?
Yes, it is used widely for mitral valve operations by the
Can the
cardiothoracic surgeons. Yeah.
okay? Can the robot be programmed for a particular surgery?
Yeah, as I mentioned, these are not autonomous robots. So the surgeon controls the robot. So if autonomous robots will be in the future, they can be programmed to perform a surgery.
And again, interesting question. The collision between the different arms of the robot automatically avoided.
There is a collision between the arms, but that's we have to adhere to certain principles when we are putting the ports and docking the robot, so to avoid collision. And the newer instruments are much sleeker when compared to the old instruments. So collision is minimal with the conventional XI system.
Okay, so can the robots be used to teach surgery techniques for new doctors before a new doctor actually operates on a real person?
Yes. As I've shown in the video, one of the features of the Da Vinci has it has dual console. There is a console like similar to what the surgeon sits on, where the assistant can sit, and the the controls can be interchanged between the assistant and the surgeons, and that's how we commonly train the new surgeons.
Okay, so I think I noticed as well. You mentioned about 90% of the prostate cancer surgeries are done by robotic surgery
Yeah,
uh, technique, and how soon can you predict that will go above 90%?
pretty soon I would say. In the next 5 years, almost 99% of the operation should be done by robot.
Okay, so this is an interesting question for me as well. Is the preference to connect the robot via fiber optic cable or 5G cellular connection?
Yes, it is a possibility, and I have recently had a chance to speak one of the R&D leads for a major mobile company, and he says that they are trying 6G technology as well, which is much faster than 5G, but that will be in place in the next probably decade or so.
Yes, that's right. I think we work a lot about 5G, and 6G is just beginning to be, well, discussions, initial discussions.
Yeah.
Then the next question is, what do you think will be the most exciting development or challenge for medical robots in the future? Is there anything they might enable surgeons to do, cannot currently be done?
The exciting things would be the incorporation of artificial intelligence and machine learning, which the trial is kind of machine learning, measuring the automatic performance metrics of the surgeon, which will uh, warn the surgeon if he is doing any wrong movement. And that would be the exciting thing. And also the development of miniature robots and nano robots in the future will be the exciting thing.
Can an active MRI system be used with non-magnetic robot hands, perhaps for the future?
Yeah, yeah, I think so. But that's beyond my scope. But it is a possibility. Anything can be possible in the future.
Okay, so this is about the future and what are the advantages does CO2 have over other gases?
Right. The CO2 is an inert gas. The advantages is when we are using diathermy, uh, there is no combustion by the CO2 gas. It is also non-toxic. Even if it gets absorbed into the bloodstream, it doesn't produce any effects.
Okay, so just browsing some of the long questions to make sure that we haven't asked those. So, is the veterinary world using robotics?
Yes, they are using robotics. Yeah.
Do the surgeon's hand control have active feedback so that he can feel what is happening at the site of the surgery?
That's a very good question. Uh, the main one of the main disadvantages of the Da Vinci system is the haptic feedback is not there. The haptic feedback means exactly what the question is, that the surgeon cannot feel or see what type of tissue it is. But with the Da Vinci system, the experienced surgeons gain experience by vision and the tissue deformity. But the new robots which are coming up in development, they have incorporated haptic feedbacks into their system. And I'm sure that Da Vinci will learn from them and also introduce the haptic feedback in the future.
Um, okay, so this is again few questions we answered. Um, do you record operations for possible claims?
Yeah, we do record operations for possible claims, and also we record operations to reflect upon our surgery, what went wrong, and to learn from it.
Okay. More use can be made of the machine. Do you envisage surgery being done remotely in a country, a different time zone? I think you mentioned that as an example.
Yeah, it is. It can be done. I think the Lindbergh operation has proven that it can be done. The main the hamper for this technology is the transmission or the latency. If we have advanced fiber optics, then we can remotely perform operations without any delay or the latency.
So this is, I think we are almost 8 o'clock. Just maybe few more questions. Five
Yeah,
past, we will stop.
yeah.
And I would like to ask if there is a limitation in performing robotic surgery recently due to the COVID-19 pandemic.
In fact, in COVID-19 pandemic, laparoscopic surgery and robotic surgery are proven to be more safer to operate than a conventional open operation. So I would recommend robotic surgery in COVID-19 situation, which is much safer.
Do you have an engineer present when operating in case of technical glitches?
We have a very good online support 24 hour 7 by the intuitive guys. So if we got any problem, we call them and they are available. They guide us. But the engineer service the robot on a regular basis.
Would would a patient know that a robot would be used for his operation?
Yeah, that's we discuss with the patient. We take the consent, and some of the patients are curious to see the robot before their operation. So before putting them to sleep, we take them to the theater and show the robot.
Then the last few questions. Um, what proportion of the day are most robotic machines used in the UK? What time?
Proportion. Yeah, the usual day, it's an elective procedure. In emergency settings, it is not used because a lot of trained staff is involved. But in elective situation during daytime, uh, it is used.
So you mentioned that the cost of the individual instruments and tools was a downside of robotic surgery. Are these end tools modular or single use?
The instruments are specifically designed for 10 uses, so they can be reused up to 10 for 10 patients. And after that, the instrument expires, and we have to use a new instrument.
Then a lot of systems in the presentation seem to have 7 degrees of freedom.
Yeah.
Would the addition of more degrees be beneficial, or would this decrease how intuitive the robot would be to control?
No, the more the degrees we add, that will be more beneficial for the surgeon.
Okay, so let's take the last question. What is the power consumption of a robotic system?
I have no idea. We operate in the NHS, so the power consumption should be significant because it is a machine, and two machines are being operated. So I would say the power consumption would be significant, but it offsets the benefits the patients achieve.
Okay, so I think unfortunately we overran as well, and
Yeah.
loads of questions. I have to stop there.
Okay.
Apologies if I couldn't read all the questions, or I think you did a great job, Smriti. So before we go away, I think I would like to do a few thank yous. Firstly, the ones who helped us behind the scene from the IET headquarters, and some of our committee members. And also, wow, Murthy, what a presentation. I have never, I think, chaired such a fascinating presentation,
No,
very
thank you.
interesting videos. So this is something I wanted to do for many years, but it took this long to find an expert, and you gave, it's worth the wait, I have to say. In fact, registration, usually lots of people register, but the turnout ratio is very low. But I have to say, it's, you have broken that record as well. We had very high number of participants compared to registrations, so that shows the interest. And loads of questions, your answers were very clear, you presented very well, and I learned a lot. So thank you very much. It was a great pleasure
Thank
to
you.
host you, and you did a brilliant job. And thank you very much, Murthy. I think it was a fantastic presentation.
Thank you, Abhaya, for giving this opportunity.
So finally, thank you very much all for joining, and also as I mentioned, Murthy has kindly agreed that this presentation be recorded and available online. So if you have missed, or if your friends wants to watch, and the presentation slides also will be available in IET Berkshire channel, YouTube channel. And if you Google IET Berkshire, you will find all our presentations. And stay tuned for interesting future events. And thank you all for joining. So good night.
Good night. Thank you very much.